Thank you all for being here. I'm going to give a slightly modified presentation from what we just delivered at the ADA Clinical Update Conference in Houston, like a month or so ago at this point. I don't know where time goes, but we wanted to present to you what we presented there, as we think it was really impactful for our team and getting to know everyone there as well. So the topic of the talk is reframing type 1 diabetes care, and really it's lessons learned from what we've learned here at Blue Circle Health. And so our learning objective is really to understand the barriers of type 1 diabetes care, which I know many of us in this room are dealing with every day, to consider how the current standards of care can be met via novel approaches to care, and to review the outcomes and lessons learned from what we've been able to serve here in working with you all. And so without further ado, I think it's really important to call out the topic of this talk, which was reframing care. Because oftentimes, and I am guilty of this as a physician, we define care as what we are doing in the exam room or at the bedside direct with a patient. We think of care as that one-on-one or team interaction. And really, I think I would challenge us all to think about what care is if you put yourself in the shoes of someone living with type 1 diabetes. Care truly is a list of things that a person needs access to in order to live a long and healthy life. These are things like insurance, financial means, transportation to get to appointments, access to figure out how to talk and fight with their prior authorizations and things like that. All of these things are care to the patient, not just that one-on-one, which is very important as well. And I think we can all agree on this, and I know we've talked about this in this room before, is the U.S. healthcare system makes it difficult, expensive, and often impossible for people living with type 1 diabetes to access that care, education, and support that they need to live and to thrive with this condition. And so I want to give you a real life example. And I am trying to remember which clinic this patient is affiliated with. So this may look familiar to you, but this is a patient who so graciously shared her story with us. Her name is Ariana. She's a 26-year-old single mom living in the state of Florida who was able to share her experience with us both before and after her time in our program. And I'm going to share a small 1-minute video with you all. And as you listen to that, I want you to listen to Ariana's words and what she is defining as care for her in her life.
I remember being in college and having to save and also ration my insulin itself because I was paying out of pocket for insulin. And that's kind of how the low parts of diabetes have been for me. And then also health issues. I've gone through DKA. I've actually passed out and had a diabetic coma, essentially. I had to be revived by paramedics, which was really scary. I didn't have health insurance. 1 month's supply was $300. So I would try to make that stretch. And rationing is something that's scary because you're playing with your health and your safety and in effort to prolong your life. I remember having to go to essentially a court setting and advocate for my need for an insulin pump at 11 years old. And that's kind of something that sticks with you because that's, you're at such a young age needing to advocate for your care. So I had suddenly lost my job. I got a job really quickly, but that job didn't have health insurance.
And I'm going to cut her off there. Words that you might have heard that maybe resonated, advocacy, finance, employment. Those are the things Ariana said that she needs in order to be healthy and to live her life with her young child with type 1 diabetes. And so with that in mind, I want to talk about the numbers because this is what it comes down to. We know 70% of U.S. counties don't have a single practicing endocrinologist. And for those that do, all of us know those wait times. They don't look very good. There's a high there's a high barrier to accessing specialists with type 1 diabetes. And we know that education is critically important, but only 5 to 7% of people living with diabetes ever see a certified educator. And I have worked in healthcare systems where we have wanted and referred to educators as much as we can, but they were frequently cut because reimbursement was not there for the hospital system. So it was not sustainable for them to continue to provide for the patients that needed it the most. We know when surveyed directly, primary care doctors said that they were, quote, not at all confident managing pumps or CGMs. And honestly, who could blame them? They're dealing with many different conditions within a 20-minute, if we're lucky, appointment. And there's not the concurrent support for them. The educators don't exist, as we just talked about. And so how could that be successful for anyone in that situation? And then insulin rationing remains common despite recent policy efforts intended to improve affordability and access. And we know insurance is preventing barriers to device and care access. And with policy changes, this is just getting worse. And so these are the dire numbers. And as a result, I truly believe this is not about the haves and the have-nots, because when you look at the numbers here in that left circle here, only 1 in 4 people living with diabetes meet healthy A1C targets as defined by an A1C less than 7. This is across the board. And, of course, it is worse for those with less. There's a 4 times greater mortality rate for people with lower socioeconomic status. And so this is translating directly to preventable complications and premature death of thousands of people every single year. And the issue is not that we're not spending money on it. We are spending a lot of money on it. It's what we do and do not spend money on. And so this was kind of back of the napkin math of saying we are seeing that insurers are paying an average of $19,000 annually per person living with type 1 diabetes. And of course, that's not enough because the person living with diabetes is landed with out-of-pocket medical expenses averaging $4,200. And if you multiply that sum by 2 million people living with type 1 diabetes in the US, you get a whopping $47 billion. That is a lot of money. It is not that we're not spending money on it. It's what we're spending the money on. And so if you believe this quote, which I do, is that every system is perfectly designed to get the results it gets, then what we've designed is a really poor system. And in order really to do better, we have to redesign care. And that very graciously was the gift of the Helmsley Charitable Trust of Blue Circle Health to say, how can we redesign type 1 diabetes care to achieve better outcomes at lower cost? In the fall of 2021, the trust got everyone together to say, how can we answer this question and what can we do? And so thus formed the Blue Circle Health Company, a 501c3 public charity really made possible due to funding from the trust. And the design principles, I know you've heard, right, what we do and the services that we have. We've been working with you all, but I think it's important to kind of come back to the roots of why we've built what we have. The entire point is to build trusted relationships with the patients, with the people living with type 1 diabetes that tell us what are the services they actually need. What did Ariana need? She may or may not have needed to see an endocrinologist. What she actually needed was to speak with a case manager to talk about employment and advocacy and transportation. So trusted relationships are the foundation, and trusted relationships with all of you to make sure that we're providing care together with the patients that we're seeing. We basically have 6 months, as you know, at Blue Circle Health to get someone from here, to equip, to educate, and to empower them to live a long and healthy life with type 1 diabetes. And everything we do is making those individual care plans and working together as a team. And this is a reminder, but at the end of the time here at Blue Circle, we have that full circle status where we can meet patients where they're at. If they're ready to go with us, we finish their time here. We might extend, and you might have seen that with some of your patients that we share. And some patients are re-enrolling. If life changes, we're here for them in the future. And so I won't go through all the details of this slide because I know that you know all this, but this is a reminder here for you all. This is just the program and how we kind of summarize who we are and the services and programs internally that we have. And a big reminder, it is free for all. It is all telehealth. And we're trying to make sure that we can be there in the ways that people need us and create these plans that are different for me than they are for the person next to me. Our eligibility criteria is on the screen here. Again, this is a reminder to you all here, but also a reminder if there's any questions on this, we can always answer that as well. And we've served over 1,200 participants since January of 2024. And so many of you are in this room referring patients and sharing stories with us. And we've had patients from over 600 different clinics. So we're just so honored to be part of that story together with you all. And these are outcomes that we have brought up with you before, but I want to remind you that none of this is really worth it if it's not improving the lives of the patients. And so what we're finding is that we have had consistent improvement in diabetes related to stress. And last year we submitted and published at the an ADA abstract showing 9 out of 10 categories of improvement of diabetes related to stress, which has really been an inherent part of our program, as well as showing consistently high patient satisfaction scores and very promising A1C reductions, which we are currently embargoed, but we will be very graciously presenting to you all at the ADA this summer. So if you're there, please stop by and we'll share those results with you, and we'll share our updated DDAS results as well. So lessons learned, and this is really kind of the gist of why I wanted to be able to present this to you all, but our being able to share what we've learned is really a part of our mission to make sure that we can all do this and we can all learn from this, and we are not working in a silo, because what is the point of that? And so without further ado, I'll just talk about our first one here. First one is that care should prioritize empowerment via self-management. Type 1 diabetes, I'm preaching to the choir. This is a self-managed condition in which the person living with diabetes has to make hundreds of decisions every single day on their own and doesn't have an endocrinologist in their back pocket to answer every question, nor is that the right person necessarily to answer these questions. So what we do know is to empower that person, to give them the tools they need. We need more diabetes educators in the room. We need to prioritize connection to educators. And most importantly, I encourage all of us to consider how we can increase diabetes education reimbursement and covered sessions, and petition to policymakers to do so, because that is what's going to give patients the empowerment, the education, the tools, the confidence that they need to make those decisions on their own every day. And the other thing is removing the need for clinician referrals. Why would we put a barrier to education by having to see an endocrinologist in many systems and many insurance plans to say, yeah, sure, you can see someone to educate you? That shouldn't exist. And so that is one of our big takeaways here. Also, access to community is healthcare for type 1 diabetes. And I know you've heard from Sarah and Scott and Kelsey and Erica, who are here today, and Morgan, about their team, the community engagement team here at Blue Circle Health, and they're all about community. And when we really learned that community is so important, when we truly learned that on the care team side, we have actually made quality improvement changes that said one of our quality metrics is to offer community to 100% of the people who enter our doors at Blue Circle Health, because we have felt that this is just as important as the insulin that goes in their body. And so we are encouraging prescription of community, encouraging connection, and finding the right fit. And this can be anything. This could be attending a breakthrough walk, joining a Discord group, attending a community session virtually. There are so many different communities that exist out there. And in fact, again, the community engagement team pulled together a nonprofit coalition with almost 20 different nonprofits to come together to say all of us should be in the same space, and we can provide one common calendar. It's hosted on our website. It can be hosted anywhere, where anyone who lives with type 1 diabetes can go to the website and see, is there something coming up? Is it near me? Can I join it? And see what's out there for them. And here are, I forgot I put this in here, here are the 17 different nonprofits that are working together and coming together on this. And so a really exciting way for us to, again, develop this community with each other for the entire T1D community. The other thing we learned is the importance of language. And I pulled this up because this is the ADCS language guidance tip sheet. I showed this in this meeting like over 2 years ago. It was a very long time ago. And I think I showed all the options at this point. So I'm just pulling out 2 examples here of how important language is. We could historically have heard, and we have heard very often and still do, the term diabetic. How long have you been diabetic? And really the preferred language is how long have you had diabetes? Because we want to make sure we're putting the person first, that we're not using a disease to describe a human. This is a disease that they might have and they might live with, but not something that defines them. Also, we hear a lot these terms adherence and non-compliant or compliance, and really it puts a lot of blame and shame on a patient. And so really, again, coming back to that concept of what is care for the patient, there's so much more than a number that you're seeing on the screen. And maybe it's in finances. And so it's taking the insulin whenever she can afford it. And so the importance of language, and there are so many more on that guidance tip sheet and other articles out there that I'm happy to share with you. But I wanted to pull that out because that was a big learning for us. And on that note, there are two takeaways that I have taken really to heart from learning from my patients and from my team, who also, many of them live with type 1 diabetes, are two questions, two of these three that I'll talk about just for a moment here. Is this concept of being in the room with a patient, and instead of pulling up an AGP report and showing the little red area on the screen and might say, well, you're getting low 4% of the time, you're under 70 this often, what should we do about it? It's reframing that question to maybe starting off and saying, what feels low for you? Because sure, they might have under 70 a specific percentage of the time, but the patient has come back to me and said, there's no way I feel comfortable going below 140. When I go below 140, I feel shaky. I feel terrified because I had a low. It required glucagon in the past. It was really scary, and I didn't know if I'd get through it. And so I avoid it at all costs now. And that is something that should be addressed. And it's a very different conversation than immediately just harping on a number that I think is important, but there's much more to it than that. And this last one is tell me how that number makes you feel. And we could, again, talking about that AGP report, walk in with a patient. And to be honest, I was taught this of going in and saying, your A1C is 6.5%. Wonderful. I know, this is a great number. You're doing so well. Let's talk about your thyroid the rest of this meeting, because it sounds like that's really doing great. Instead, I've walked into rooms with patients and say, your A1C is 6.5. Tell me how that makes you feel. And I've gotten the answer before, well, hey, doc, I feel terrible. I'm food restricting. I'm avoiding seeing my family and my friends because they gather around food, and I am isolated and I am depressed and I am alone. And I thought you'd be so proud of that 6.5, but I feel horrible. That is a very, very different conversation. And imagine how much trust I would have lost had I just said, great job with that 6.5, like they've heard from everyone else, and not gotten to really what is at the heart of it. So these are some takeaways that we've learned here, and I've been fortunate to learn from my colleagues as well. Another takeaway here is designing novel care models doesn't mean ignoring the standards of care. In fact, it means upholding them. And so when we think about the ADA standards of care, I'm not going to read all the words on the screen here, but this is just one excerpt from the updated standards that if you were here last time when Natalie and Diana were presenting our updated standards, some of these things were in there as well, but this was under the category improving care and promoting health in populations. And it talks about, shared decision-making, quality improvement, coaches, community health workers again. How can we take these standards of care and develop novel ways to figure out how to meet them in the context of our current healthcare system? And what we learned was we thought going into this that we're such a different approach here. We're a telehealth system that deals with type 1 diabetes only. Like, how can we stand up to all of you who are providing this amazing care in person with all of these health conditions? And so we wanted to pursue the ADA education recognition program status, and we were very fortunate to get that. But we went through this process back and forth with the ADA. And in that process, we were able to share our design and get feedback. And actually, someone from our team was invited to help develop the next ADA and ADCES standards of DSMES care. And so it was really a refreshing process for me. And I think my takeaway for all of you is if you're developing a new process, a new system, have a new QI project, share your designs and ideas with the ADA, get feedback, because you can actually have a massive impact in designing the next standards. And I know all of you are just advocates for your patients and doing these incredible things. And I think there's ways for all of us to come together and get together and push the boundaries in what we can do in the type 1 diabetes space. The other thing is importance of measuring and caring for diabetes related distress. I talked a little bit about our outcomes. Also, this might be a familiar face to you, as are some of the other faces in here. This is Sherry from our care team, and she's one of our educators. But I did want to talk about, I can digress, I did want to talk about diabetes related distress here for a moment, because we know, and I've talked with some of you about this before, that when distress is addressed, patients do better. And we know that it's associated with higher A1Cs, lower medication use, missed visits, lower quality of life, and that it's highly prevalent. And we know when people live with distress, which again, it's very common, if we don't do anything about it, if we don't address it head on, 88% of patients continue to report high distress 6 months later. It doesn't go away and it doesn't get better unless we address it. And it is responsive to intervention. We can have an impact and we can make it better if we do talk about it with our patients. And so I bring this up to encourage all of us to figure out, is there a way we can incorporate this into our clinic? What it is a lot of questions. And so I understand that time is of the essence, but are there ways maybe at new patient registration for your clinic, are there ways that we can incorporate 1 or 2 questions to talk about some of these things with patients so that that becomes part of how we might address their overall care and their overall well-being? So these are some of the questions that come on that diabetes distress scale. It will give you an overall report, and then it will break it down by category. And if you think about it, a lot of these categories here are some of those things that Ariana, for example, that so many of our patients talk about as part of their care. Well, my fear of lows, my financial worries, technology challenges, these are the things that they're struggling with. And so this is a really nice way to break it down and to be able to develop those conversations with them and hit them head on. And so these are tools available for free online, diabetesdistress.org. The Behavioral Diabetes Institute, who hosts this, who has built it, they're incredible people. They're brilliant. They've worked with us in many different ways. And I really encourage you, if you have questions on this, to reach out to them as well. And I'm going to come back to Ariana, because we've talked a lot about what care is and what care means and how we can talk about that in the context of our healthcare system. And so let's hear from her in her own words and what she has to say now.
My life has drastically improved. I have really great insurance. The insurance counselor through Blue Circle was amazing. She was so knowledgeable. She got me the exact plan that I need for myself that covers absolutely everything. And she was able to help me get signed up for the prescription assistance program. And I got approved, which was amazing. And I was able to get 90 days of sensors for free, which I feel like I've been through so much and not much makes me that emotional, but having to not worry about the financial aspect of that as a single mom who's rebuilding is, it's really comforting and, nice to have that level of support where I feel like I haven't had that. And I'm finally able to let other people in, which is great. So yeah, I'm crying. It's a twofold thing because I have the support and I also feel better and I'm better able to actually take care of my type 1. And that wouldn't be possible without Blue Circle. So yeah.
I really appreciate her being so gracious and sharing her story. And of course, Ariana's story is so unique to her, but it is such a really powerful presentation of so many of the patients that we see and so many of the patients we're seeing with you all. So I'm sure her story sounds quite familiar. And I just want to say and acknowledge and call out that really it's our mission to help all those living with type 1 diabetes, and we cannot do it alone, nor were we meant to do it alone. Everything that we have done, everything we've built has been through conversations, through ideas, through feedback from every single one of you and all the communities we've come in contact with in this space. So we are just so grateful for that opportunity and to be here with you all. And if there's ways that we can collaborate and come together and develop things further for those living with type 1, please reach out. We're here. Of course, we're here every month, but you also have my personal email here on the screen, and you have information on our website at any time. But I will stop there and pause. And if there's any questions or comments, I am here. But I really appreciate this. I tried to talk as fast as I can to squeeze this all in. So thank you so much for listening.